Welcome to episode 219, Skin Picking and Other Body-Focused Repetitive Behaviors, Attachment, Emotion Regulation, and Sensory Sensitivities, featuring Stacy Nakell, licensed clinical social worker. Make sure to subscribe to be alerted about future episodes by Clearly Clinical. Learn, grow, shine. Hello to our listeners. My name is Beth Irias, and I'm excited today to have a conversation with social worker Stacy Nakell. One of her specializations is understanding body-focused repetitive behaviors and the way that many people may do things like hair pulling or nail picking and any number of other behaviors that she'll talk about. But I'm excited to hear Stacy's perspectives. Thank you so much for joining us today.
Thank you. I'm happy to be here.
So before we dive into this conversation, why don't you tell our listeners a little bit more about you and about your background and how you came to have this particular specialization?
Sure. Well, I am a licensed clinical social worker. I have been practicing since 2002, and I came to this population sort of by accident and became a specialist in working with this population based on how people were coming to me and realizing what a hunger there is in the community for what I have to offer. And so the first time I experienced a person coming to me about trichotillomania, I didn't know what it was, and I had to look it up. And what I found when I looked it up was that there was some information. This was also back in 2002, and there was some information about hair pulling, and not very much information about how to treat it from a psychodynamic perspective, which is where I was coming from. And so even back then, I had a sense, where's the book I want to read? And that led me eventually to write a book about my treatment perspective.
Wonderful. Before we kind of dive into the model, I would love for you to do a quick 101 and reintroduce some terms that we clinically may know, but may have forgotten over the years. So you just mentioned trichotillomania. Can you kind of give us the background information to set up today's conversation?
Definitely. So in the current DSM, all of these behaviors are under the umbrella of obsessive compulsive and related behaviors. Although a number of researchers have recommended that there be a clinical category for body-focused repetitive behaviors because they have more in common with each other than with anything else. So these include trichotillomania, which is hair pulling, dermatillomania, or excoriation, skin picking disorder is the term in the DSM, and that's skin picking. And then also includes behaviors like nail biting, cuticle picking, nose picking, and a variety of behaviors, anything that involves relating to the dermis within a self-soothing perspective.
When looking at the boundary line between what our culture and the DSM consider atypical body-focused repetitive behaviors, I know you just said nose picking. Can you lend some more explanation about where the line is of when this very human thing that we do can cross a line into being considered a diagnosis?
Yes, and that's a great place to start, actually, in the reminder that everybody engages in some kind of body-focused behaviors. And so we can all relate to it. I think people who struggle at the clinical level often feel very alone and feel very ashamed because it feels like it's such a strange behavior to engage in. And sometimes that's the first thing I do is remind people that we all pluck hairs, we all pick pimples, we all scratch at mosquito bites. And so all of that is part of being human, which is also part of the fact that as humans, we are animals, and all animals engage in grooming behaviors. And that's what we're talking about. So the way it gets to a clinical level is if it begins to go beyond that grooming function and begins to serve as really a coping mechanism for other experiences, and then also has side effects that can interfere with daily coping. So a lot of that is social people become very self-conscious about maybe the bald spots that arise if the hair pulling gets really intense, and then also scabs and scars, or ragged cuticles, bloody cuticles, those kinds of things where people engage in either having to hide and camouflage some of the side effects, or just sit with that embarrassment and shame. And so that's where it can really snowball into affecting all parts of life. And that's when it becomes a clinical issue.
Thank you. So, when looking at BFRBs, body focused repetitive behaviors, can you speak a little bit about the prevalence? Because I remember learning it years ago and being kind of stunned and of how many of us do this.
Yes, definitely. So different studies have shown different percentages. So somewhere between 0.6% and 3.5% of the population fits into the clinical diagnosis of one of those body focused behaviors. But when they look at, maybe there's studies that look at just people who identify that this is an issue for them, that maybe not reaching the clinical level, but that they do struggle with some version of body focused repetitive behavior, the number goes up to more like 13%.
Thank you. With that in mind, is something that is pretty remarkably common. It's something that I think many clinicians are seeing in their offices and that may not even be recognized. Like, how many of us appropriately screen for BFRBs? Can you talk about assessment through the lens of someone who specializes in it?
Oh, what a good question. So definitely that's the first line of addressing this possible the possibility that somebody who comes in to see us is struggling with these behaviors. So I always encourage people to put right on their intake forms, along with any number of other symptoms, hair pulling and skin picking, as just a way to normalize that those may be things you're coming in with, but also as a way to encourage people to identify those things as something they may be struggling with. Otherwise, I have people who come to see me after having worked with therapists for many years and never mentioning that they struggled with one of these behaviors.
And can you speak a bit about the dominant treatments available currently for BFRBs? So, for clinicians who appropriately assess and who have identified these conditions, what are the most common things in our clinical toolboxes?
Yes, so the TLC Foundation for BFRBs, which used to be Trichotillomania Learning Center and shifted its name, they are the main organization in charge of research, and they put on conferences and have a scientific advisory board that came out with an expert consensus about what works for hair pulling and skin picking in particular. And they have endorsed only cognitive behavioral therapy as a treatment modality that is useful. And they have added on different treatment modalities such as DBT and ACT, so dialectical behavior therapy and acceptance and commitment therapy. They've added on to the cognitive behavioral model, and this is partly because the cognitive behavioral model has been shown to have some real drawbacks. And so adding on other pieces, but that is still the only expert endorsed perspective on what treatments are helpful. One of the dynamics that goes into that protocol is that you are not supposed to look at the roots of the behaviors and treat the behaviors as the problem in and of themselves. And in that expert consensus, there is also the idea that these behaviors are not related to underlying traumas or underlying emotional difficulties, and can be looked at in and of themselves. And so from a psychodynamic perspective, where we're always looking at the roots of behaviors, and also from a trauma-informed perspective, where we're always looking at the possibility that any trauma that we've experienced may influence later behaviors, I've had to really carve out my own path in creating an evidence base for psychodynamic treatment and the efficacy through case studies in particular, which is the way that psychodynamic therapy can be assessed. And it's a little bit less fancy in terms of you don't get all of the numbers and the data and the this and the that, but the case studies that really reveal on an individual level how transformative going to the roots and healing the roots can be in a really long-lasting way of reducing reliance on those behaviors.
Thank you. As someone existing in the world who has absolutely observed these behaviors in people in my environment, I can think of a specific loved one that when tough topics come up, there's a hand that goes up and spinning those curls, spinning her hair, and that's where it's clear to me that this is one of the many ways that we soothe ourselves. Can you talk a bit about BFRBs through the lens of attachment theory and why you feel like there's such a relationship here?
Yes. Well, let me say first that what you just said is something that I encourage all therapists to pay attention to in our therapy rooms in particular. Whether you know that somebody's struggling with a body-focused behavior or not, the fact of when somebody's hand goes to their hair or their cuticles or their skin and starts looking is a wonderful intervention point for us to be able to look at what happened just before your hand went to your hair. And usually there is something we can tie to that is a stressor, and we can begin to connect. That is the trigger for that movement, and help people reconnect and become more aware of what draws their hand to their skin or hair. So just that was a brilliant intervention that you just threw in there that we can all benefit from. When I came to understand these behaviors as self-soothing behaviors, it became clear to me that there is something involving attachment that must not have gotten fully developed. And this is because current neurobiological research really shows that self-soothing is not possible without first relational soothing. So, meaning that we learn how to soothe ourselves in relationships, and co-regulation is how we learn self-regulation. And we sort of understand that children are learning how to regulate themselves based on the input of their attachment figures. And we don't think about that when adults are also trying to learn new coping strategies, that we can't just give them a worksheet to build in a new coping strategy, because learning to cope is learning how to soothe oneself in relationship and then internalize that. And so it became clear to me that attachment must be involved, and there must have been some disruption in attachment that led people to need a little bit of extra soothing. So looking at the literature, what I found was that really across the board, even from some of the cognitive behavioral therapists, they were looking at what precipitates the development of the body-focused behavior usually in adolescence. And almost always there's a precipitating factor that involves attachment. So this could be divorce is a very common one, but it could also be the loss of a loved one, perhaps the loss of a beloved grandparent who is very soothing, or moving and losing friends and having to reestablish roots. Or it could also involve a medical complication where somebody is, maybe their mother has to go to the hospital for an extended period, and then so the loss of an attachment figure that way. Or they're in the hospital and dealing with having to regulate without their usual comforts. So it became clear that attachments are really regulators, and if we're losing an attachment or attachment is disrupted, we're going to have to find an extra layer of self-soothing. And that's where the body-focused behaviors really come into play.
Thank you. I want to take what might be an odd tangent. Having recently been to a lovely zoo that had a wonderful chimpanzee exhibit, had the opportunity to sit there and observe how these family members were taking care of each other. And so they were picking and they were soothing and petting each other. This is perhaps one part of our humanity that we sometimes overlook.
Yeah.
You're nodding. Can you speak to that? You had mentioned like the grooming behavior coming from all different animals. Can you speak a bit about like humans as animals in relation to this grooming behavior?
Yes, definitely. So that's one of my favorite parts of both studying body focused repetitive behaviors and then also incorporating some of that research into the work I do with people in terms of building self compassion. Because it is true that animals engage in body focused repetitive behaviors. And it is also true that they do not do that in the wild. So they only engage in body focused repetitive behaviors like maybe a bird will pluck its feathers, or we've probably all seen when our dogs or cats over groom, over lick. Sometimes that's related to a dermatology issue, but also it can be related to self-soothing. And so what is so exciting about that research is that uh, vets have been able to come in and look at, well, what are the factors that are creating this behavior in this animal? And they've been able to identify the environmental factors that sort of get in the way of that animal's natural expression. And so they've noticed too that when they change the environment, oftentimes that behavior will reduce. And so this is really exciting in terms of being able to help people understand this is not just something weird about you or something wrong with you. This is really about how your system is not getting all of its needs met in the environment. And if we change the environment, that can be true too, that your behaviors can be reduced. And the 4 categories that they found in animals, they also really apply to humans. So that's boredom, frustration, isolation, and the sense of being in too small of a space. And those are the same 4 triggers that are ongoing for most of my clients. And the sense of being trapped in too small of a space can really, for humans, be being trapped in any kind of a way, in a relationship, in a job, with parents who are really restrictive. And so we can expand that, but also understanding that we are animals. And so when we even think about boredom, just like those birds, they get bored and restless because they're not allowed to perhaps fly and do their natural things. And when you think about us as human animals, we are often trapped into too small of spaces, especially starting in school, where we're kept at our desks for 8 hours a day when the human need is really to get out and play for much more of that time. And so we can start to see that the systems that we're in, just like they can be restrictive to animals, there are also ways they restrict our human impulses. And that in and of itself, even if we don't think we're bored, we think our mind is engaged, our bodies can be bored.
Mm. Thank you. And just to restate them so that we can remember them, please tell me those 4 again.
Sure. So isolation, frustration, being trapped in too small of a space, and boredom.
When thinking about the context of medical with body focused repetitive behaviors, knowing that more and more is appearing in the research about uh, conditions like OCD, for example, or autoimmunity, some inflammatory disorders, where we see the development more of body focused repetitive behaviors. How do you see it when there's like a medical contributor that may be factored in?
Okay. So I want to make sure I understand your question in terms of how body focused repetitive behaviors can go hand in hand with a lot of other kind of medical and or psychological issues. So what I've come to understand about that, and it is true, there are many different psychological conditions that often go hand in hand. We call them comorbid conditions. So very common comorbid conditions with trichotillomania and dermatillomania are depression, anxiety, ADHD, autism, and also PTSD. So these are very different kinds of conditions. So what I've come to understand is that picking, pulling, and biting they're almost too good at managing our physiological and emotional state. So they can bring us to some sense of homeostasis from any number of states. So if somebody is anxious, picking and pulling may actually soothe their nervous system. Whereas if someone is depressed, picking and pulling can actually lift their nervous system and bring more feeling in. For post-traumatic stress disorder, picking and pulling can actually lead to a trance-like state that leads to escape. Whereas for ADHD, picking and pulling can actually lead more into a concentration. And so I think of the use of the skin as being able to regulate physiological and emotional states from every direction.
Thank you. I appreciate that. I guess one of the questions I have, how about the neurocognitive side of it? I would imagine that when we're touching ourselves and soothing ourselves, that there is some dopamine, serotonin, like what is going on there from a chemical level to understand why this may feel good.
Yes, well, that is something that I think could be studied a lot more. Um, the studies that I've found really relating to that dynamic are actually more the animal studies, where they do find that when animals engage in some of these behaviors, it does release endorphins. And so, and we can all sort of have a sense of that too. There's people who engage in body focused behaviors often talk about a release and a relief. And so the idea that just like horses, just like the birds, we're also releasing some feel-good chemicals in our brains makes a lot of sense. And that momentary relief, release, pleasure is what maintains the dynamic, because even though afterwards there's a sense of perhaps shame, perhaps then the feeling of the negative consequences comes in of maybe it hurts or there's loss of hair or there's some consequence. But then even that sense of kind of shame or negative feeling leads back to, well, now I need to pick or pull to kind of get rid of that feeling. And so it can really become a cycle. And I do think that researchers who study the brain could probably learn a lot more about how that cycle works in the brain, but there's not a lot of research about it yet.
When considering the attachment piece, so you had mentioned earlier the soothing of the nervous system and relationship. When other people are touching us in a soothing manner, I'm thinking of a loved one or a caregiver, an authority figure touching a child in a loving, soothing manner. How do you see that kind of playing out and relating to the understanding of body focused repetitive behaviors? And then the next level, really like the management.
Yes. So I like to start at the very, very beginning of life and thinking about how we all have an understanding that when a baby is born, we understand why the doctor is going to put the baby on an attachment figure's skin for skin to skin contact immediately. And that feels very intuitive, that all of the nerve endings in our skin are part of what's going to build that first attachment, that where the baby starts. It was in this very enclosed space, all of the needs met and soothed and touched in every way, and comes out into this crazy world. And that sense of containment begins by being held skin to skin. And so that is where emotional regulation and attachment both begin. So I like to think about something like skin to skin contact. I like to think about it as a soft comfort. And as a baby grows, we introduce many soft comforts that both are related to the attachment figure, feeding in particular, with all the senses bathed in sort of goodness, and then maybe we put the baby down and we give the baby a transitional object that's also soft. So a blanket with like a ribbon. And there are lots of soothing components to that soft comfort, or a teddy bear. And so if we go from soft comfort to soft comfort, that's how we learn to regulate our own emotions. Now, if there's something in the way where we can't fully be soothed in the soft comforts, maybe our attachment figure isn't able to fully relax while holding us and bathing us in all of those good senses, and we have some dysregulation, we may not seek a soft comfort when we're on our own, but there's also comfort in harder things. So, for example, you think about babies, and they usually put gloves on or mittens on so that the babies don't scratch their face. But you'll see that if a baby maybe is crying for a few moments and there's no response, or the caretaker isn't available immediately, then the next step might be to scratch, because scratching creates a sensation that relaxes the nervous system, even though it's not that soft one that has no side effects. Now it's a hard one that leaves a mark. So that's how I think about, in general, how the skin relates to self-soothing. And one extra element is that this population tends to have difficulty with sensory processing. And there may be any number of hypotheses about why that might be. But what it means is that it's harder to be soothed by soft comforts. And so a parent may find that this is a difficult baby to soothe. And so that baby is already at a little bit of a disadvantage and already might need to seek out other ways to soothe. And that's where those harder comforts come in. We can even think about this as adults. We have so many hard comforts. We have our hug from a loved one or a blanket ourselves, but we also smoke, drink, overwork, all those kinds of things that manage our emotions, but don't necessarily provide what we're really, really deeply looking for.
Thank you. And I want to go back to one thing you had said earlier about the comorbidity of body focused repetitive behaviors. Looking at the neurodivergent population, I appreciate how you just brought up sensory processing sensitivity. Can you speak a little bit more about that? Speaking as someone who has sensory processing sensitivity myself and is neurodivergent, I understand this. But if you can speak a little bit more about that for folks who maybe are not as familiar with it, I think it's helpful information to understand kind of the full picture of a person in front of us and how their sensory system may be different than somebody else's.
Sure. So when I'm training therapists on working with body focused behaviors, I really note that these behaviors are just like any other behaviors, right? It's not some different category like eating disorders and substance abuse disorders. They're all doing the same thing of soothing the central nervous system and providing some calming. But it's really helpful to know some of the specifics about challenges this population faces. Number one, because then they feel seen and heard and understood. And one of those things is knowing some common details that are very ubiquitous. So, for example, one of the first questions I'll ask a new client is, when you were younger, did you have any difficulty with the lining on socks or the tags on the back of clothing? And just that question often makes people feel like, whoa, how did you know me? Because that's one element of that sensory dysregulation, is that those things that most people can just ignore really irritate somebody who has a skin sensitivity and a difficulty processing sensory input onto the skin. But that can also look like hearing sensitivity. It can also look like sensitivity to the textures of certain foods. And again, that's really a lot of the overlap with autism and ADHD, is that sensitivity. And so parents need to learn to relate a little bit differently to the skin of that particular kid. And in autism, we know Temple Grandin kind of recognized that sometimes an autistic child needs to be hugged hard and held versus softly touched. And so that can also be the case with people who end up struggling with these behaviors later on.
Thank you. You had mentioned some cognitive behavior therapy interventions that are commonly used, or even models, you talked about DBT, ACT, CBT, these tend to be pretty highly manualized, and are, as you said, looking at this behavior and targeting the behavior versus looking at it through the lens of coping and attachment. Um, Tell me more about the element that you're wanting to add in there. And like, as you talked about, an attachment wound, trauma, like where it is not necessarily as manualized and more kind of catered to the needs of that particular client and their presentation of body focus repetitive behaviors.
Sure. Well, let me start actually by saying the one gift that I feel like the CBT community working with this population really gave to the to my understanding of working with this population, as well as just it seems really important, is that they include a sensory component so that fiddle toys are part of therapy. And so I will say that is really key. I'm not saying that there's no place for cognitive and behavioral strategies. Cognitive and behavioral strategies are woven throughout my work. The difference is that I see the therapeutic relationship as the primary healing modality. And if we look through an attachment lens, that makes a lot of sense. Again, I'm not just going to tell somebody to go find fiddle toys and play with them and that will solve their problem. What I might do is work with somebody on regulating their emotions in a session as we're talking about something difficult, and then encourage them when their hand goes to their hair to pick up something from my fiddle tray and learn to use that in that context, but also within our relationship. And sometimes I may even give that fiddle toy to that client so that it becomes a transitional object from the soothing and the feeling they have with me, and can take it with them. So it's a very relational way to engage with even the behavioral interventions. And along with that, so we're looking at, if we look at the precipitating factor and we go down to those roots, some of the things we're talking about in therapy are revisiting some of those wounds. And so revisiting grief. A lot of my clients found that their grief became stuck because partly the way that we navigate grief in America is not very relational, not very very. It sort of has this idea that we'll get over it within this certain period, and so oftentimes there's a lot of residue of grief that needs to come out of the body physically. So we'll be attending to the loss of a grandparent in when the person was 12, and maybe that's the first time they've ever had of really sobbing in relationship with me, with another witness, sobbing and letting go and being comforted. And then that can actually clear something out so that that restlessness in the body is not so acute.
You had mentioned something that I want to go back to, which was the observed impulse, or the person says that they are feeling inclined toward whatever body focus repetitive behavior, and the introduction of something like a fidget toy to kind of redirect. Talk to me more about that kind of replacement intervention. We have had prior conversations on the podcast talking about vestibular sensory input, and how for some folks, like, that's a way to ground. And sometimes fidget toys, I mean, I'm thinking about all these different sensory tools out there, but all of these things are ultimately somehow body focused. Is it a matter of like a replacement behavior, or can you speak a little bit more about that?
Sure. So, first of all, I think everybody has their own combination of sensory needs that are met by the picking or pulling behavior, and they're not always the same. So the same fiddle toy is not going to work for everyone. I always encourage people to go to a toy store and feel, or even a fabric store and feel, and find what you notice soothes your nervous system. So what I like to think of is this is only one piece of the puzzle. So we need to, first of all, be addressing the underlying roots so that the urges to pick or pull go down. So I like to think of kind of an inner cup of stress. And if our inner cup is all the way filled up, the urges to pick and pull are going to be so high that there's no replacement behavior that's going to be helpful. And a lot of people get really frustrated because their urges are really high and they're given this replacement behavior, and then maybe they try to use it and then they feel like they failed. And so that's one of the downsides of focusing just on the behavior, is that oftentimes, even if someone can stick to it for some period of time, when the urges are too great, there's nothing like that behavior that to really meet that need. So I think of it in terms of, we have to lower the stress in the cup, and then we have a choice. When the stress is not so crazy and the urge is mild, we're still in charge of kind of our prefrontal cortex, and we can take a choice to say, okay, I know the hair, if I pulled my hair, it would probably feel better, but right now I can pluck off the legs of this toy caterpillar and that will do enough. So thinking of it, and the way I've thought about my approach is really integrative. So it integrates that sensory and replacement behavior within both the therapeutic relationship and the deeper exploration of what's really triggering the picking and pulling.
Got it. So when thinking of it in the relational context, it's really making it a place where this is not shameful. This is not something you need to hide. This is part of your humanity. And let's see if we can maybe work the nuance so that it's something that's perhaps less physically harmful or disruptive. As you're talking, I'm thinking back to a harm reduction model. We have a really interesting interview on the podcast talking about self-harming behaviors and harm reduction. As I'm saying the term harm reduction, you're nodding. Can you speak about that piece of it? Because some of these behaviors, as you've already mentioned, can be really physically disruptive. I mean, the risk of infection, potentially permanent damage to the skin, to the nails, because of the severity that can occur.
Right, definitely, and I love that idea of harm reduction, because the other element, and there are some personality characteristics that are also common among people who pick, pull, or bite, and I do make some hypotheses about that in my book and kind of connect some of the dots. But perfectionism is huge for this community, and a sense of sort of overfunctioning and people pleasing is in there. And so if you just focus on reducing the behavior or getting rid of the behavior, even worse, if you say like, okay, let's get rid of this behavior so you'll never do it again, then you're really setting up a perfectionist to really do a great job and really try to please the therapist and get that A plus, and then a relapse. And as many of my clients have pointed out, it takes so long to grow back hair, for example, and it takes 2 seconds to pluck out all that growth. So we really want to avoid this idea of success and then relapse. And I really think about it in the terms of a moderate level. And I have to really work with my clients often on shifting the expectation, because I let them know it doesn't matter when you may have not picked or pulled in 10 years, but if a new stressor comes up, especially a loss, a relational loss, you're going to still fall back on that particular behavior. And we have to work on sort of, again, like interrupting that cycle where, okay, now we can say, I engaged in this behavior. I understand why I did. I love myself anyway. And then I'm not going to fall back into the cycle. I usually tell people, one common intervention I do is I ask people to name their spots. So if somebody has a new spot that's just been picked at, I'll ask what stressor led to that spot. And, the same thing happened actually in the pandemic. People who had really reduced their picking and pulling behaviors really increased them, because look at what the pandemic created: isolation, frustration, boredom, and a sense of being trapped. Right. So a lot of people were able then to identify, this is now my pandemic spot. And that really takes away that shame and gives us a model where we're looking to moderate our behavior, and even more so, just put in more and more healthy ways of grooming and healthy ways of coping with our emotions, so that there's less pressure on these hard comforts that used to be our whole repertoire.
When you're working with a client, what language do you use? You just use the term healthy coping. The opposite of that could be unhealthy coping, which to a perfectionist ear might land
Yeah.
differently. What language do you use with clients that you feel is particularly adapted for folks who often have so much shame associated with the behavior?
Yes. Okay. So well, I don't mind that. I don't personally mind that distinction with healthier coping and less healthy coping, because I think we all have a sense of this is not ideal. This is not the way I want to cope. When I'm picking my skin and bleeding, that doesn't feel healthy, right? But one of the things that can replace that is, can I engage in really positive grooming behaviors, so that I'm touching my skin in ways that feel that both feel good and don't leave a mark. And so I think I work really hard on reducing shame, but also not necessarily sugarcoating the fact that this is not the healthiest way of coping that we can find.
Thank you. I appreciate that answer. In family systems where one or more people have body focused repetitive behaviors, I'm curious, how do you feel about the involvement of a significant other? So I'm thinking of a teenager who has a default of lip picking in response to stress, and a caregiver who observes this, or a sibling who observes this, and we can make some assumptions about what that behavior is bringing to them. Is it ever recommended to have another person involved to try to soothe the nervous system? So does the parent walk over and rub the teenager's back to provide some sensory input? I'm just curious, because then it becomes predicated, potentially linked to somebody else providing sensory soothing, instead of it being something that I'm giving to myself.
Well, first of all, I love the way you framed it, in the system of a family. And again, I feel like in that question, you're already setting the stage for the way that I think about these behaviors, and the ways that I encourage families to think about them, which can be very difficult for families. Sometimes families really want to say, this behavior in this child is the problem, and I want you, Stacy, to fix the problem. And I always say the family is a system, just like you said. The family is a system. And honestly, these individuals are not only the most sort of physiologically sensitive, but they tend to be the most emotionally sensitive. So anything that's not getting discussed or worked through in the house, this is the kid who's going to pick it up and pick up that energy, and that is going to turn into restlessness in their hands. So I love that you brought in the family as a system, because I can only really work with families if they're willing to accept that the environment that we're talking about also needs to change in some ways if we're going to help the kid get better. So along with that, a lot of parents have to work on, first of all, forgiving themselves for their first reactions to their child engaging in these behaviors, because it's really normal just to be like,
Just
stop it.
stop. Yeah, just stop.
Yeah.
Put your hand down. Simple enough.
Yes, yes. And that's because it's painful for a parent to see. And a parent doesn't want their child to suffer in that way. And, of course, the desire is to fix it for them. What I often do in the first session with teenagers is, we always have some communication with the parent, and we'll talk about what has the parent already tried to do, and did it work or not? And then, is there anything that the child would like or thinks would be helpful from the parent? And parents always have an easier time if the child can say, yes, actually, I want you never to say don't do it, but if you want to just give me a little touch, and then ask me if there's anything I want to talk about. That can be one way that a parent can be helpful, but parents struggle so much when the child says, no, I just want you to leave me
Mhm.
alone.
Mhm.
And just like with eating disorders, one of the components of this behavior is that there's one thing we can control is our own relationship with our own body. And so we really have to let each person be in control of the input they want from friends, family, or others. And if they say, no, I don't want that, it's really, really hard. But loved ones' job is really to listen to that directive and empower the person to at least get to decide how other people relate to their behavior.
Thank you. I'm thinking about it in the context of some OCD treatment models, and I'll explain the relationship that I'm seeing, and I'm curious what your thoughts are. Let's pretend that you have a teenager that has OCD, and one of the manifestations is wanting to take pictures of many, many things in their environment to catalog them. If I don't have these photos, then they don't exist, and I feel really out of control, and I feel lost, and I feel scared. Some OCD therapists would say to the parent, "Do not take the picture." That by kind of giving in to the urge, that we are reinforcing the quote unquote maladaptive behavior. If we were to apply that same reasoning to body focused repetitive behaviors, where it's like, do not do it, prevent it from happening, do not do anything to replace it, do not get involved, you as a caregiver, because then the child or adolescent or loved one may become dependent on you to soothe themselves instead of developing it themselves. These are very hard line approaches. There are many ways to crack a nut. I'm curious for you, as someone who's looking through the lens of attachment at body focused repetitive behaviors, what your reaction is to kind of a hard line approach of squelch the behavior.
Yeah. So, well, first of all, I guess because I have that idea, I'm based in neurobiology, that we learn how to soothe by being soothed by others. I would never discourage a parent to be part of the soothing. I think of um, again, like it has to come first. We have to be soothed by someone else, and then find a way to transition to soothing ourselves. So that piece is a different emphasis. Um, in OCD again is very much guided by behavioral interventions. I would, while I don't focus in on any other versions of OCD. I, I, there is enough that I've seen and worked with in connection with the body focused behaviors and the ways that they can connect with other OCD behaviors that I would again say there's a message in there. Why pictures? Like, so I really don't understand, even just from my own theoretical perspective, I don't understand why we would not be curious about why is it pictures that are making this person feel more safe in the world. To me, that's a metaphor that we have to unpack, and that behavior is really communicating something very important. So the idea of kind of squelching it is maybe even the opposite of what I would be interested in. I would be interested in exploring it and trying to fully understand what is it about taking pictures, and where did that come from? What's the root of that? And how did that come to stand in for some other form of safety? So I would just have a different, again, look at the whole system and try to understand how that behavior developed and what exactly it's helping that person cope with. And it's very, very frustrating for parents. It's so much slower. And the behavior goes on while we're exploring, and parents, that drives them crazy. And yet, again, where I'm interested in long-term healing in ways that then that person can pick up on whatever developmental steps have been lost. And that is a longer term process than just trying to change a behavior.
In having this conversation, I'm also realizing this to me goes back to my feedback informed treatment nerdiness, which is, number one, the importance between the relationship between client and therapist, but also the fit between the perspective and approach of the clinician and the goodness of fit for a client. So what may work very well to come at things from a highly manualized worksheet approach for some folks may fall completely flat. And even just that acknowledgement, I think, is an important one, because whenever any of us are presenting a model, hopefully there's a group of people who've responded really well to it, but there's also probably a group of people who haven't. And then we need to go back to the drawing board. The example I give is it's like a rash. It's like if you keep trying the same treatment and your doctor keeps giving you the same cream and it's not working, at what point is it like, we need to change up the treatment? But I appreciate the flexibility in what you're saying here. It's not like you have to come at it this way. It's like, let's pull from different models to create something that may be maximally responsive and helpful for this particular client and understanding their worldview and what this means for them.
Yes, and it's so funny that you mentioned a rash, because that leads into my whole nerdy fascination with the field of psychodermatology, which is a developing field that isn't even well. I don't think that a lot of people have even heard of it, but it is a field that connects psychiatry, dermatology, and psychology, and looks at that one rash actually can both create psychosocial stressors by the embarrassment of the rash and all of that, but also can relate to something internally is being expressed in that rash. And so I love that mind, body, skin, psyche connection that field really represents. And so that rash is more than just a rash.
That's a really interesting example. Thank you for sharing about that. That term was new to me and it makes so much sense. And I think it goes back to how often we as human beings like somaticize. And in different cultures, how often either that's acknowledged and addressed, or in other cultures where we may ignore it or chalk it up to a medical condition without observing kind of the context, as you had mentioned earlier, like when does this occur? Why is this occurring? What's going on in this person's body? So going back to kind of the idea about attachment theories as being foundational to potentially understanding body focused repetitive behaviors, I'm out in the weeds again. Looking at different models of attachment, do you see like, is this an anxious attachment thing, or is this just a interrupted attachment thing?
Yeah. So, gosh, that's a good question, and it's funny because some local colleagues of mine have just now, like this week, published a book, Secure Relating, by it's Sue Marriott and Ann Kelly, and so they're actually looking at a little bit of a different take on attachment, that we think of it as attachment styles, but they really look at it as attachment states, and that uh, we can all shift in and out of all the various versions of attachment based on who we're with and what's coming up for us. And so I really like that particular model when we think about this, because I think it's not just one attachment structure that may be found throughout. I think there is something disrupted in attachment, and that can look very different in a lot of people, but still lead to just a little bit of extra need for comfort. So I would say definitely people who are more on the sort of ambivalent side of things might find themselves picking when their attachment figure is not available, and they may also know, oh, that's why I'm picking. Whereas somebody who's a little bit more avoidant may not have any idea that they might miss somebody, but they're still picking. And so the behavior itself can kind of cross all of the dynamics. But what I will say is that when you look at the more intense picking and pulling and the more intense consequences, so the people who are really struggling with the medical consequences, who are getting deep infections, that's a signal that there's more disrupted attachment, and that the possibility of deeper trauma is really something we need to be assessing for, because there's more that's being communicated in those behaviors. And so I would say it goes across the board.
Thank you. I know it was kind of an out there question, but I was just thinking about it. I'm still struck by what you had shared earlier about the observation of these body focused repetitive behaviors in animals and the situations that can inspire them, I think is so powerful when we are looking at it through the lens of humans as animals. And then how are we as medical and or mental health professionals responding and seeing that kind of contextual factor that is so easy to overlook.
Yes, yes. And I will just put in a little bit of a plug for that one of the four triggers, that frustration trigger, and just how important it is to address that in therapy. There has been some research showing that the internalization of anger in particular is a trigger for these behaviors. And if you think about horses, male horses who don't have any other male to play with and get that aggression out will tend to bite their flank. So it's a real clear example of self-harm and why the self-harm is happening. It's not happening because the horse doesn't like herself. It's happening because she's frustrated. And I guess it would be he in this case because it's the males. But so it happens because he's frustrated and he just needs to get that frustration out. And so that's also an element that I think of in terms of my work as a therapist. One of my jobs is to help my clients get their frustration out and to be a safe person to get their frustration out at. And so I tell them from the first session, there are going to be times when I annoy you, when I miss you, when I say the wrong thing, when I do the wrong thing, when I ask you about your hand going to your hair and it really is not what you wanted to talk about. And I encourage them from the very first session when they feel that to share it with me. And oftentimes, because we're working with people who are so pleasing and especially trying to please authority, even though I've said that to begin with, I still have to notice it when it's happening. And I can pick up on the body language when somebody's irritated or something's not hitting and I'm missing it. And then I can bring them out. So therapy as a place to express anger and to learn that you can do that and your attachment figure won't collapse or fight back, but can just hold and contain it. That's one way of picking up on a developmental need that might not have been met in childhood.
Thank you for that observation and explanation, because I think it is so illustrative in how we get it out, that it sublimates. The energy goes somewhere. And if as you mentioned, anger in this case of the horse example, the anger goes somewhere. It doesn't just disappear. And we've had some interesting conversations on the podcast relating to someone's lived experience of marginalization, so often under acknowledgement of anger, certain emotions that either can't be expressed publicly or aren't even acknowledged internally because they're associated with so much shame, and the consequences can be so severe. So I appreciate you kind of acknowledging that part of it, that there's potentially this well of significance underlying what may appear to be pretty simple behaviors. For people who are listening and want to learn more about this confluence of attachment and psychodynamic theory and body focused repetitive behaviors, what resources do you recommend?
My book called Treatment for Body Focused Repetitive Behaviors, an Integrative Psychodynamic Approach. And I will say, so the BFRB.org is the TLC Foundation for BFRBs, and they do have a lot of really good resources, although they don't necessarily bring in this more complex element of that I think is so important. I still recommend that people go check them out. And also just exploring the topic of psychodermatology. There's an organization, the APMNA. It's a really long name, but they offer seminars and workshops and conferences as well. And if people are wanting to learn more about that, it's a really, really fascinating field.
Wonderful. Stacy, this has been such an interesting conversation. You mentioned your book is a resource. If people want to learn more about you and about your work, what's the best way to do that?
Sure. They can just go to my website, stacynakell.com. And I have a lot of blog posts that I wrote up until I published the book. So a lot of the pieces that are in the book were first thought out in my blogs, and I offer a training group for therapists. I have a couple of openings in that group, and that's open to anyone, anywhere. And all of that you can find information about on my website.
Fantastic. Again, for our listeners, we have had the pleasure of hearing from Stacy Nakell, licensed clinical social worker, about the relationship between attachment, emotion regulation, and body-focused repetitive behaviors. Thank you so much for joining us today, Stacy. I really appreciate it.
Thank you so much.
You've just finished listening to another exclusive Continuing Ed podcast by Clearly Clinical. If you like what you just heard and you need continuing ed credits, please visit us at clearlyclinical.com to check out our 1-year membership, where you'll have access to our growing library of continuing ed podcast courses. Clearly Clinical, where our goal is to help you learn, grow, and shine.